Okay, let's unpack this. Welcome to the Deep Dive Ortho, where today we're plunging into the really intricate world of sports injury recovery and, crucially, that pathway back to peak performance. Whether you're dealing with elite professional athletes, dedicated amateurs, or maybe those enthusiastic weekend warriors, the universality of sports injuries is, well, it's undeniable, isn't it? You might actually be surprised to learn that almost 1.5 million people here in the UK end up in A&E departments annually because of sports injuries, and the average is something like 8.6 million sports-related injuries occurring each year overall. It's a staggering scale, really. It highlights just how common these setbacks are and, I suppose, how frequently we, as medical professionals, encounter them in our practice. The path to healing, as we know all too well, it's never just straightforward, it's often complicated, it's nuanced, and let's be honest, frequently fraught with challenges for the patient and for us. So, understanding not just average recovery times, but critically the mechanisms of effective rehabilitation and those robust prevention strategies. Well, that's absolutely paramount for us if we're going to optimize patient outcomes. Today, we're incredibly fortunate. We have an orthopedic specialist with us, ready to guide us through this intricate landscape of healing, safe return to play, and very importantly, avoiding that cycle of re injury.
Thank you. What's truly fascinating here, and perhaps often overlooked in the rush, is that effective injury management really transcends mere timelines. While those recovery periods give us crucial benchmarks, don't they? The real emphasis, particularly for us as medical professionals, lies in understanding the myriad individual patient factors, the underlying biomechanics of the injury and the sport, and fundamentally applying a truly comprehensive, patient-centered approach to care. So our objective for this deep dive is really to provide you, our mid-senior medical professional colleagues, with clear, actionable insights. Perhaps a robust framework for optimizing patient outcomes in sports orthopedics, ensuring you feel equipped to navigate even the most complex scenarios effectively.
Right. So when we discuss sports injuries, it's clear we're not talking about a single entity, are we? It's a vast spectrum of physical trauma, and each type seems to have its own intricacies. Could you maybe start by helping us define what constitutes a sports injury in a practical, clinical sense? And perhaps elaborate on the common acute symptoms patients typically present with that should immediately flag for us the need for a really detailed assessment.
Certainly. From a clinical and, I suppose, a research perspective, a sports injury is fundamentally defined as, well, any physical complaint sustained by a player that results from their sport or training. The original definition mentions football, but it applies broadly across all sports, obviously, and consequently prevents them from taking full part in future activity. Now, the nuance for us as clinicians is discerning when a complaint, or perhaps a niggle, crosses that threshold into a full-blown injury requiring intervention. It isn't just about pain. It's really about a functional deficit that restricts participation. That's the key. So when a patient presents with an acute, sudden injury, our immediate focus has to be on identifying key indicators that guide our initial assessment and management. These are signs of significant tissue damage or structural disruption. Things like extreme swelling or bruising around the affected area that suggest internal bleeding or significant fluid accumulation, or noticeable weakness of the injured limb, indicating possible muscle or nerve impairment, and significantly limited mobility of the joint that can point to joint effusion, ligamentous instability, maybe even a mechanical block. Crucially, we look for an inability to put weight on the affected limb or joint. That strongly suggests a significant lower limb injury, like a fracture or severe ligamentous instability, a real red flag. Then there's that sudden severe stabbing pain, often characteristic of acute trauma. And of course, a bone or joint appearing visibly out of place, a clear sign of a dislocation or a gross fracture requiring immediate reduction and stabilization. Those are our immediate red flags demanding swift and comprehensive evaluation.
Okay, that's very clear on the red flags. And the types of injuries themselves, as you said, are incredibly diverse.
Hugely diverse, which means we need a tailored approach right from the start. Sprains and strains, for instance, are perhaps the most common things we see. The sprain involves the stretching or tearing of ligaments, those tough, fibrous bands connecting bones and stabilizing joints. We often grade them, don't we? Grade 3, mild stretching, up to grade 3/3, a complete rupture. We frequently see them in wrists, ankles, knees. A strain, on the other hand, refers to stretching or tearing of muscles or their tendons, which connect muscle to bone. Common sites include the hamstrings, quads, the groin area. The key clinical challenge here is often differentiating between the grades accurately, because that significantly impacts the prognosis and therefore the rehabilitation plan. A grade I ankle sprain might recover in days, literally, whereas a grade 3 hamstring tear, that could take months of quite complex rehab.
A huge difference.
Absolutely. Then you have fractures, or broken bones. Now, it's an interesting clinical paradox sometimes, but some simple, stable fractures can actually heal in a shorter time frame than a severe, high-grade soft tissue injury. For example, a non-displaced distal radius fracture might be biologically stable in 6 weeks. Compare that to a grade 3 hamstring strain that might require months of careful progressive rehabilitation. Common bones fractured in sports include fingers, arms, specifically the humerus, radius, ulnar collarbones, the clavicle, ribs, even the neck and toes, often due to direct impact or significant twisting forces. Our role is to identify the type as its spiral, common transverse, the location, any displacement, because these factors really dictate whether we manage it surgically or non-surgically.
Right, the classification drives the management.
Precisely. Then, moving to more severe soft tissue injuries, we frequently encounter ligament tears. The anterior cruciate ligament, the ACL, in the knee is a prime example, sadly. It's a major knee ligament, essential for rotational stability and preventing the tibia sliding forward. Its rupture, often occurring in those non-contact pivoting movements you see in football or netball, is a devastating injury. It fundamentally compromises knee function. The clinical challenge for us is recognizing the subtle signs perhaps of a partial versus a complete tear, and also managing the often coexisting injuries, like meniscal tears or MCL sprains, which are quite common with ACLs.
Yes, the unhappy triad comes to mind.
Indeed. Then tendon injuries form another critical category. This encompasses a whole spectrum, from tendinopathy, which is more of a chronic degeneration, to acute ruptures. Common examples include Achilles tendon ruptures at the back of the ankle. Patients often report a distinct pop and immediate weakness. Rotator cuff tears in the shoulder, particularly affecting overhead athletes. And epicondylitis, more commonly known as tennis elbow, which is typically chronic overuse injury of the common extensor tendon at the elbow. Differentiating that acute rupture from chronic tendinopathy is crucial for treatment planning.
And what about younger athletes? They present unique challenges, don't they?
They certainly do. A unique and particularly concerning category is growth plate injuries. These are specific to individuals whose growth plates, or physes, are still open and actively growing. This makes them vulnerable areas, sort of weak links, for overuse or acute trauma. Key examples here include Little League elbow and Little League shoulder, which are overuse injuries seen predominantly in young baseball players due to those repetitive throwing mechanics. The risk here isn't just immediate pain, but potential long-term growth disturbances, or even deformity if they're mismanaged. So a high index of suspicion is needed.
It's definitely something to keep in mind with adolescent patients.
Absolutely. And finally, we cannot overlook concussions, which are essentially mild traumatic brain injuries. These are particularly prevalent in contact sports, rugby, American football, boxing, even football with heading. Patients typically present with a constellation of symptoms: headaches, confusion, dizziness, nausea, maybe visual disturbances after an impact. The clinical challenge lies in their often subtle presentation, the need for serial assessment over time, and strict adherence to graded return-to-play protocols. This is vital to prevent things like second impact syndrome or post-concussion syndrome. For us, the key is recognizing them immediately, removing the athlete from play without question, and ensuring comprehensive neurological assessment and follow-up.
That's a very comprehensive overview of the injury spectrum we face. Given this diverse nature, then, what are the primary factors that truly dictate the length of a patient's recovery period and their projected return to activity? It seems to be far more nuanced than just the initial diagnosis, doesn't it?
You're absolutely right. It's definitely a multifactorial equation. We have to integrate several critical elements when we're thinking about prognosis and timelines. Firstly, the injury severity and type are paramount, obviously. Consider a simple, non-displaced metaphyseal fracture of the tibia, for instance. That might typically heal biologically within about 6 weeks. But contrast that with a severe ligament tear, perhaps a complete ACL rupture, especially if it's a multi-ligament knee injury. That can necessitate a recovery timeline of approximately 6 to 12 months, particularly if surgical intervention is required, and often even longer for a full return to competitive sport at the same level. The biological time needed for tissue repair varies hugely, and we simply have to respect that.
So biology dictates the baseline.
It dictates the baseline, yes. Secondly, the anatomical location plays a significant, though sometimes underappreciated role. Injuries affecting the wrist and elbow, for example, often involve a lengthier recovery period when dealing with broken arms. This isn't just due to their complex anatomy with multiple small bones and joints. It's also because of the high functional demands placed on these joints in daily life and in almost every sport. A stiff wrist or elbow, even after a seemingly simple fracture, can profoundly limit an athlete's ability to return to their sport. Weight-bearing joints like the knee or ankle also have unique challenges related to load acceptance and proprioception.
That makes sense. The functional demand is key.
It is. Thirdly, individual patient factors are absolutely crucial and cannot be overstated. It's imperative to recognize that a patient's age significantly impacts healing rates generally. Younger individuals heal faster, though not always better in terms of scar tissue. Their overall general health, including nutritional status, plays a role. The presence of comorbidities like diabetes, peripheral vascular disease, or autoimmune conditions can all significantly extend the healing process by impairing cellular repair mechanisms or blood supply. Lifestyle factors such as smoking, which is known to delay both bone and soft tissue healing, and even psychological factors like fear avoidance behaviors, anxiety, or depression can profoundly affect adherence to rehabilitation and perceived pain, thereby extending recovery. These elements directly impact the body's intrinsic ability to repair and regenerate tissue, and it's our responsibility as clinicians to screen for and manage them, or at least acknowledge their influence.
So it's truly holistic.
It has to be. And finally, a patient's adherence to treatment and rehabilitation is, in my view, one of the most critical determinants. And perhaps where we, as medical professionals, working alongside physiotherapists, can make the biggest difference. Following early medical advice rigorously and engaging consistently with structured rehabilitation programs are paramount. Impatience, a tendency to play through pain, or perhaps a failure to grasp the long-term consequences of non-adherence can invariably lead to re-injury. And that, in turn, results in a much more protracted, complex, and frankly disheartening recovery cycle for the patient. It's a message we must continually reinforce, often requiring a blend of education, motivation, and sometimes empathetic firmness.
That brings us perfectly to the critical initial response to an injury. The RICE method, rest, ice, compression, and elevation, has long been a cornerstone for managing acute injuries, hasn't it? Could you elaborate on its practical application, but crucially for our audience of mid-senior professionals, what are the nuances and perhaps even the evolving perspectives on its role during that critical first 24 to 36 hours post-injury? Are there any common misconceptions or newer approaches we should be aware of?
Yes, RICE is indeed foundational, particularly for those basic, minor soft tissue injuries like low-grade strains and pulled muscles. It's really about providing immediate support to minimize the initial damage and control the acute inflammatory response. Rest is the first component. Simple enough, it means limiting activity and avoiding putting unnecessary mechanical stress on the injured limb. This allows the body's natural healing processes to begin without further aggravation. Next, ice. This helps to limit swelling and pain primarily by causing local vasoconstriction and reducing nerve conduction velocity. The correct application is crucial, though. Use a cold pack or ice bag wrapped in a damp towel, never directly on the skin, applying it to the injured area for approximately 20 minutes, repeated maybe 4 to 8 times a day in those initial stages. Here's a key nuance. It's critically important to highlight that heat should not be applied immediately after an acute injury. Ice is for acute inflammation, typically within the first 48-72 hours. Heat is generally reserved for later stages, maybe for chronic conditions or muscle soreness, to relax muscle tension and promote blood flow to healing tissues. Applying heat too early can worsen swelling and inflammation.
That's a really common mistake, isn't it? Applying heat too soon.
It is. Then compression. This involves applying an elastic bandage to the injured area to help reduce swelling by increasing interstitial pressure and encouraging fluid reabsorption back into the lymphatic system. The caution here, and this is important for clinical practice and patient advice, is not to wrap too tightly. Overly tight compression can impede circulation, potentially leading to things like nerve damage or, in severe cases, even compartment syndrome. Check capillary refill distal to the bandage. And finally, elevation. Simply keeping the injured limb raised above heart level. This simple action uses gravity to help facilitate fluid drainage, thereby decreasing swelling.
So RICE is still the go-to for basic first aid.
For basic first aid, yes. But for the nuances for mid-senior professionals, while RICE is practical, modern sports medicine has evolved somewhat. We're now seeing a shift towards concepts like PEACE and LOVE for soft tissue injuries. These are mnemonic devices advocating for a more comprehensive approach. PEACE stands for protection, elevation, avoid anti-inflammatories, compression, education. LOVE represents load, optimism, vascularization, exercise. It brings in psychological factors and the importance of early appropriate loading. The avoid anti-inflammatories point is particularly pertinent and debated. While NSAIDs reduce pain and swelling, there's growing evidence that they can, in the very early acute inflammatory phase, potentially blunt the natural healing response, particularly for some soft tissue and bone injuries. The inflammatory cascade, while causing pain and swelling, is actually part of the body's essential repair mechanism. It brings in the cells needed for cleanup and rebuilding. So our counsel often moves towards simple analgesia like paracetamol for pain control in the initial days, rather than routine blanket NSAID use, especially for fractures or significant ligament injuries. It's a more nuanced approach.
That's a really important update on the thinking around NSAIDs. So, beyond RICE or PEACE for minor injuries, what about more significant musculoskeletal issues? Immobilization comes into play then, doesn't it?
Absolutely. For more significant musculoskeletal injuries, immobilization becomes a necessity. We use devices such as slings for shoulder or arm injuries, splints for fingers or wrists, braces for knees or ankles, or casts for fractures. They provide vital support to the injured limb. This support effectively reduces pain, swelling, and muscle spasms by preventing unwanted movement that could disrupt the repair process. It protects the healing structures, allows tissues to approximate, and facilitates pain control. For instance, for a moderate wrist sprain, perhaps a grade 2 ligament injury, a removable splint might be prescribed for, say, 2 to 6 weeks. Patients are typically advised to wear it during activity for comfort and protection. But, importantly, they're often encouraged to remove it periodically, perhaps at rest, at night, and during bathing, to allow for gentle, controlled, early range of motion exercises when appropriate. This helps mitigate the risk of excessive joint stiffness, which can be a real problem with prolonged immobilization. So the decision to immobilize and for how long is always a balance. We're balancing the need for protection of healing tissue against the significant risks of joint stiffness, muscle atrophy, and even things like complex regional pain syndrome. It's not always straightforward.
That balancing act is key. Beyond this initial response and potential immobilization, patients often experience significant pain, which, as you said, can certainly hinder their cooperation with early interventions or even just rest. How is this managed effectively, and what's the role of pharmacological interventions in these initial stages, especially bearing in mind the NSAID caveat you just highlighted?
Pain management is, of course, a critical aspect of patient care right from the outset. Uncontrolled pain isn't just unpleasant. It impedes rehabilitation, affects sleep, which is vital for healing, and can actually lead to chronic pain issues down the line through central sensitization. For many acute injuries, over-the-counter pain relievers, such as paracetamol, can often be sufficient for managing mild to moderate discomfort. It's generally safe and doesn't have the same concerns regarding healing as NSAIDs. For more severe pain, perhaps after a significant fracture or surgery, we might consider short-term use of stronger analgesics, like codeine-based medications or occasionally opioids, but always with extreme caution regarding potential side effects, constipation, nausea, drowsiness, and the very real risks of dependence and addiction, even with short-term use. We follow the analgesic ladder approach. As I mentioned, and it bears repeating, nonsteroidal anti-inflammatory medications, NSAIDs, need careful consideration. While effective for pain and swelling, they can potentially stall the bone healing process for fractures and may even negatively impact soft tissue healing in that very acute phase. The mechanism seems related to their inhibition of prostaglandin synthesis, which is actually crucial for the early inflammatory and subsequent repair processes. So their use must always be carefully weighed up, particularly in the early stages of bone recovery or when significant soft tissue repair, like a tendon repair, is paramount. For us, it's always a risk-benefit analysis. Are we prioritizing short-term symptomatic relief at the potential cost of slightly delayed or impaired long-term biological healing? Often the answer is to minimize NSAID use early on, especially in high-risk situations like fracture healing.
Okay, that's a very pragmatic approach. And beyond the immediate pain control, what else should we be vigilant for and educating patients about?
Yes, our role extends far beyond just prescribing painkillers. We must educate patients on monitoring for potential complications as healing progresses. This includes vigilance for persistent numbness or tingling, which could indicate nerve involvement or compression, maybe from swelling, or a tight cast requiring urgent neurological assessment. Changes in skin color, such as a cool or bluish tint in the hands or fingers distal to an injury or cast, are red flags for circulatory issues, arterial compromise, or perhaps developing compartment syndrome. This needs immediate attention. The presence of chills or fever might indicate a possible infection, particularly after surgery or an open fracture, requiring prompt investigation, blood tests, possibly antibiotic treatment, and potentially surgical washout. Furthermore, progressive stiffness or weakness in the limb, despite engaging in rehabilitation, might signal the development of complications like arthrofibrosis, excessive scar tissue limiting movement, complex regional pain syndrome, CRPS, or even early post-traumatic arthritis. These necessitate further diagnostic imaging or intervention. Our advice to patients must always include a clear list of when to worry, or when to call the doctor, or seek urgent review. Empowering the patient is key.
This naturally leads us to rehabilitation, often lauded as the gold standard in sports injury recovery. For us as medical professionals, how do you view physiotherapy within the overall recovery journey, and why is it truly indispensable for optimizing long-term outcomes? It's far more than just stretching, isn't it?
Oh, absolutely indispensable. Physiotherapy isn't merely about restoring a range of motion, although that's part of it. It's a sophisticated, holistic process. It's aimed at rebuilding strength, enhancing flexibility and proprioception, the body's sense of joint position, and ultimately restoring full functional abilities specific to the patient's sport and daily life. It is, without any exaggeration, the linchpin of a successful sports injury recovery. As we often describe it to patients and colleagues alike, surgery, whilst it might be crucial for anatomical restoration, is only the initial, say, 10 meters of a 100-meter race. The subsequent 90 meters are fundamentally dependent on dedicated, often arduous, structured rehabilitation. Without effective physiotherapy, even the most technically perfect surgical repair can lead to a suboptimal functional outcome. The structure might be fixed, but the function remains impaired.
That's a powerful analogy.
It helps patients understand the commitment required. The impact of physiotherapy is broad and profound. Firstly, it actively promotes healing by encouraging appropriate tissue regeneration through controlled stress and load. Wolff's law for bone, Davis's law for soft tissues adapt to the loads placed upon them. Physio guides this adaptation, ensuring collagen aligns correctly and tissue matures optimally. Secondly, it significantly speeds up the return to activities for both professional athletes and recreational participants by progressively conditioning the injured area and the entire kinetic chain. More than just enabling a quick return, though, it is absolutely instrumental in preventing long-term complications. Things like chronic pain, diminished mobility, persistent weakness, and critically, that disheartening cycle of re-injury. A well-executed rehabilitation program identifies and addresses pre-existing biomechanical deficits, muscular imbalances, or faulty movement patterns that may have contributed to the initial injury in the first place. It builds resilience.
So it's proactive as well as reactive.
Exactly. And the unique nature of each injury, and indeed each individual patient, their goals, their sport, their lifestyle, necessitates the development of highly bespoke treatment plans. There's no one-size-fits-all protocol that works optimally for everyone. A skilled physiotherapist tailors exercises and interventions precisely to the patient's specific needs, their injury stage of healing, their sport's biomechanical demands, and their personal goals. This includes manual therapy, therapeutic exercises, neuromuscular re-education, motor control drills, and sport-specific activities, all progressed in a systematic, evidence-based manner. For us as the overseeing medical professionals, it's about integrating the biological healing timeframe with this functional restoration pathway. The physiotherapist is our absolutely essential expert partner in this crucial phase. Collaboration is key.
And for those more severe cases where conservative measures, including physiotherapy, prove insufficient and the discussion turns inevitably towards surgical intervention, what are the primary considerations for advanced treatments or surgical procedures? It's often a difficult conversation for patients, I imagine, balancing that hope of a fix with the reality of a potentially lengthy and demanding recovery.
It is indeed a pivotal and often challenging conversation. Managing expectations realistically is absolutely critical right from the start. For certain injuries, before jumping to surgery, or sometimes in conjunction with it, we might consider advanced therapeutic options. These are often biological treatments. Emerging therapies such as platelet-rich plasma or PRP therapy and other biologics like bone marrow aspirate concentrate, BMAC, aim to actively encourage faster or better quality healing by leveraging the body's own intrinsic regenerative capabilities. PRP, for instance, involves taking the patient's blood, concentrating the platelets, and injecting this concentrate into the injured site, a tendon, ligament, or joint. The idea is to deliver a supraphysiological dose of growth factors to stimulate repair. The evidence base for these treatments is still evolving, though. Their indications are quite carefully delineated, typically reserved for certain chronic tendinopathies or perhaps ligamentous injuries where the natural healing potential seems stalled. We must be transparent with patients about the current evidence, the potential benefits, the limitations, and often the significant out-of-pocket costs associated with these treatments, as they aren't always covered by insurance.
So manage expectations carefully there.
Very carefully. However, surgical intervention itself is typically reserved as a treatment option for severe injuries where conservative management has failed, or is highly unlikely to achieve a stable functional outcome from the outset. This includes things like complete, significantly displaced fractures that won't align properly without fixation, significant ACL tears where knee instability is profound and incompatible with the patient's desired activity level, complete Achilles tendon ruptures, particularly in active individuals where non-operative management carries a higher re-rupture risk, or extensive rotator cuff tears where the tendon is completely torn and retracted, significantly compromising shoulder function. The overarching goal of surgery in these cases is to anatomically restore structures, bones, ligaments, tendons to their correct position and provide stability. This creates the optimal biological and mechanical environment for healing to occur effectively. For example, in an ACL reconstruction, we're not just repairing, we're reconstructing a new ligament, using a graft to provide stability that conservative management simply cannot restore in a completely torn ligament.
And surgery isn't needed for the majority, is it?
No, it's important to keep that in perspective. While surgery is impactful for the right indications, only around 20%, maybe fewer, of musculoskeletal patients presenting to orthopedics generally require surgery. These decisions are always made based on a clear clinical need, weighing the patient's functional demands, the severity and type of the injury, their age and health, and the potential to achieve superior long-term outcomes compared to non-operative pathways. We assess the patient as a whole, their goals, their activity level, comorbidities, and, crucially, their willingness and ability to commit to the rigorous post-surgical rehabilitation that will inevitably follow. Surgery is just the start.
Right, back to the 100-meter race analogy.
Exactly. For patients undergoing surgery, it is absolutely critical to provide a very clear understanding of the procedure itself, including potential risks and complications, infections, stiffness, nerve injury, failure of fixation, and aesthetic risks. And as we discussed, to establish realistic expectations for their recovery trajectory. This might involve discussing specific timelines for things like returning to driving, resuming a manual occupation, or that often prolonged pathway to returning to elite sporting activities. Managing these expectations up front is vital, not only for patient satisfaction, but more importantly for their adherence to the post-operative rehabilitation protocol. A patient who understands the roadmap, the milestones, and the potential bumps in the road is far more likely to stay on track and achieve the best possible outcome. Clear communication is paramount.
That's a vital reminder of the comprehensive patient counseling required before embarking on surgery. Let's now delve into some of the most frequently encountered sports injuries and their specific recovery dynamics, drawing on these principles we've discussed. Knee injuries, particularly ACL tears, are such common and often devastating concern for athletes. What's the typical prognosis here? And for us, what does the recovery journey truly entail, particularly regarding the nuances of rehabilitation and potential complications we need to watch for?
ACL tears are, unfortunately, very common and significant injuries in sports. They're especially prevalent in high-demand multi-directional sports. Think football, basketball, netball, skiing. The anterior cruciate ligament is vital for knee stability, resisting forward translation of the tibia and rotational forces. It's frequently injured during sudden stops, rapid changes in direction, jumping or landing maneuvers, often, interestingly, without direct contact. Clinically, patients often describe hearing or feeling a distinct pop sensation at the time of injury, followed by immediate swelling, amarthrosis, and a feeling of instability or the knee giving way. Now, while a partial tear, which is less common, might see recovery in approximately 3 months with intensive conservative management focusing on quadriceps, hamstring, and gluteal strengthening, a complete tear almost invariably necessitates surgical reconstruction for athletes aiming to return to pivoting or cutting sports. Conservative management just can't restore that stability adequately for high-demand activities. This, of course, extends the recovery timeline significantly. We typically quote around 9 to 12 months of return to sport after ACL reconstruction, and often longer, maybe 12 to 18 months, for a full return to pre-injury performance levels. Patience is absolutely key.
And the rehab is notoriously demanding.
It is long and arduous, yes, but absolutely dependent on comprehensive criterion-based rehabilitation. Post-surgery, the initial phase focuses on controlling pain and swelling, regaining full passive knee extension quickly that's critical to prevent later issues, and gradually restoring flexion. Weight bearing is usually allowed early in a brace. This is followed by progressive strengthening of the hamstring, quadriceps, and gluteal muscles. The hamstrings are particularly crucial if a hamstring tendon autograft was used, but also for their dynamic contribution to knee stability, helping to protect the graft. Quadriceps strength is vital for function and preventing patellofemoral pain. We then progress to proprioceptive and neuromuscular control exercises, focusing on balance, agility, hopping, and landing mechanics to re-educate the limb and restore confidence. It's about teaching the brain and the knee to work together again effectively.
And what are the key challenges or complications we need to monitor?
Key clinical challenges during ACL rehab include managing anterior knee pain or patellofemoral pain, which is common. Preventing arthrofibrosis or excessive scar tissue leading to stiffness, particularly loss of extension, is critical in the early phase. And, very importantly, addressing the psychological fear of re-injury or kinesiophobia. The goal is not just a biologically healed and mechanically stable knee, but a brain-trained knee that the athlete trusts. Long-term complications, unfortunately, can include a significantly higher risk of developing osteoarthritis in the injured knee later in life, even with a successful reconstruction. And there's a re-tear rate that, despite our best efforts with rehab and testing, can be up to 10–20%, particularly in younger athletes returning too soon or without meeting objective return-to-sport criteria. Our role involves careful patient selection for surgery, managing those expectations for the demanding rehab, meticulous monitoring of progress, and objective testing before clearing for a return to play.
Moving from the knee up to the upper limb, shoulder injuries, particularly rotator cuff tears, are highly prevalent, aren't they? Especially in overhead athletes like swimmers, throwers, or tennis players. What are the clinical signs we should look for to differentiate these? And what kind of recovery journey can patients expect, especially given the various types of tears, partial versus full thickness?
Yes, rotator cuff tears are indeed a significant issue, particularly for overhead athletes. They account for a substantial proportion of sports-related shoulder problems. For instance, one study showed a notable 45% prevalence in college baseball athletes. The rotator cuff comprises 4 key muscles, and their tendons supraspinatus, infraspinatus, teres minor, and subscapularis, which are crucial for shoulder rotation, elevation, and dynamic stability of the glenohumeral joint. Patients typically report a deep ache or sometimes a stabbing pain in the shoulder, often felt laterally over the deltoid insertion rather than right on top. This is often accompanied by weakness or difficulty lifting or rotating the arm, particularly into overhead positions or reaching behind the back. They may also experience clicking or crackling sensations, crepitus, when moving the joint. And characteristically, the pain often worsens at rest or during the night, making it challenging to perform even simple lifting tasks, or, very commonly, sleep on the affected side. That night pain is a real hallmark.
So night pain is a key symptom to ask about.
Definitely. From a diagnostic perspective, differentiating between tendinopathy, which is more inflammation or degeneration without a discrete tear, partial thickness tears, where the tear doesn't go all the way through the tendon, and full thickness tears, where it does, is crucial, as this dictates the management strategy. Clinical examination involves specific provocative tests for each rotator cuff tendon, like empty can for supraspinatus, external rotation lag signs for infraspinatus teres minor, lift-off tests for subscapularis, assessing range of motion, and strength testing. Imaging, typically ultrasound in the first instance or MRI for more detail, confirms the diagnosis, showing the location, size, and retraction of any tear.
And how does the recovery differ based on the tear type?
It differs significantly. For tendinopathy or smaller partial thickness tears, many patients can often improve significantly without surgical intervention. The mainstay here is dedicated physiotherapy, focusing on pain management, restoring range of motion, and critically, strengthening not just the rotator cuff itself, but the entire scapulothoracic stabilizing muscles and the periscapular kinetic chain. Even then, full functional recovery can still take up to a year for some individuals. For more significant tears, particularly full-thickness tears causing significant pain and functional deficit, or acute traumatic tears in younger individuals, surgical repair is often indicated to restore the anatomy and function. The typical healing period post-surgery ranges from 6 months to a full year, sometimes even longer for high-demand overhead athletes to return fully to their sport. The biological healing of tendon to bone takes time. The recovery process after surgery is carefully structured through distinct progressive phases, guided by the physiotherapist in close communication with the surgeon. It begins with a period of protection, often in a sling, and passive motion, where the arm is moved by the therapist or the patient's other arm to prevent stiffness without stressing the repair. This usually lasts for the first 4 to 6 weeks. This progresses to active assisted and then active motion, often from 6 up to 12 weeks post-surgery, where the patient starts moving the arm themselves against gravity, gradually increasing range and control. Following this is intensive strengthening, typically from 12 weeks onwards, targeting all shoulder girdle muscles, the rotator cuff, deltoid, biceps, and importantly the core and legs, rebuilding the kinetic chain. The final phase culminates in a gradual, criterion-based return to full activity and sport-specific training, ensuring the shoulder is not only healed, but robustly conditioned for the specific demands of their sport, and crucially, for the high forces involved in overhead movements or contact. The main risk we monitor throughout are post-operative stiffness, sometimes called adhesive capsulitis or frozen shoulder, and unfortunately the risk of re-tear of the repair, which can occur.
That phased approach sounds critical for tendon healing. The elbow is another joint that sustains considerable stress, particularly in throwing and racket sports. Could you shed some light on conditions such as tennis elbow, maybe bone spurs in the elbow, and the concerning little league elbow we hear about in young athletes? What are the specific clinical considerations for managing these in a sporting population?
Absolutely. The elbow is a fascinatingly complex joint, acting as a crucial link in the upper limb kinetic chain, especially for throwing and racket sports. Let's start with tennis elbow, which medically we call lateral epicondylitis, though it's often more of a tendinopathy, a degenerative process rather than pure inflammation. This condition manifests as pain on the outside of the elbow, over the lateral epicondyle, frequently radiating down into the forearm muscles. It stems from overuse and repetitive microtrauma, leading to degenerative changes in the common extensor tendon origin, particularly the extensor carpi radialis brevis, ECRB muscle, which controls wrist extension. It's very common in racket sports players due to the repetitive wrist extension against resistance, but also surprisingly common in manual laborers or even office workers from repetitive gripping or keyboard use. Now, while it generally has a tendency to resolve spontaneously over time, full symptomatic resolution can take quite a while, anywhere from 3 to 12 months for many individuals, with most finding their symptoms completely resolved within about 2 years. Patience is often required.
And what's the best approach to management? Exercises? Injections?
From a clinical perspective, structured exercise programs are absolutely fundamental to its management. This often includes specific eccentric loading exercises for the wrist extensors, where the muscle lengthens under tension. Evidence suggests this type of exercise promotes collagen remodeling and strengthens the tendon effectively. General forearm stretching and strengthening are also important. Research indicates these exercise programs are as effective as more invasive treatments like platelet-rich plasma, PRP, or dry needling injections in the long term. Although sometimes those injections can offer short-term symptomatic relief for very persistent recalcitrant cases. Crucially, though, caution is strongly advised with repeated corticosteroid injections. While they often provide excellent temporary pain relief, multiple studies have shown potentially worse long-term outcomes, including higher recurrence rates and even potential tendon weakening or rupture after 1 year. This is likely due to the catabolic effect of steroids on collagen tissue. So we tend to reserve steroid injections for very specific situations, perhaps just one-off use for severe pain-limiting rehab, rather than repeated injections. Our clinical focus is primarily on load management modifying activities that aggravate the pain combined with that structured physiotherapy program. Patients can benefit from specific stretches like wrist extension and flexion, isometric static wrist extension exercises, forearm rotation strengthening, pronation supination, and perhaps exercises like wall slides to improve shoulder girdle function as part of the kinetic chain.
Okay, so exercise is key, steroids used cautiously. What about bone spurs in the elbow?
Right? Bone spurs in the elbow, or osteophytes. These bony outgrowths tend to develop when the bones of the elbow joint, typically the olecranon process of the ulna and the olecranon fossa of the humerus at the back, or sometimes the coronoid and coronoid fossa at the front, repetitively strike against each other. This often happens during forceful end-range extension or flexion, leading to cartilage wear and bone-on-bone impingement. The body then attempts to compensate by forming these abnormal bone protrusions. We often see this in throwing athletes, gymnasts, or weightlifters due to the repetitive high loads at the end range of motion. Patients might report a mechanical block to full extension or flexion, catching, locking, or pain, particularly at the end range. Sometimes they can even irritate the ulnar nerve passing behind the elbow. For symptomatic bone spurs causing mechanical blocks or significant pain, minimally invasive arthroscopic surgery, keyhole surgery, could be very effective. The surgeon can go in and simply shave away the impinging bone spurs, restoring range of motion and reducing pain quite dramatically in many cases. However, it's not always necessary. In many cases, particularly if the functional limitation is mild or the pain is primarily inflammatory, non-surgical approaches using NSAIDs, used judiciously here, activity modification, or perhaps a single cortisone injection into the joint, can successfully reduce inflammation and pain in the irritated joint, potentially obviating the need for surgery. We treat the patient, not just the X-ray finding.
And what about the little league elbow? That sounds quite specific.
It is, and it's of particular concern for our young athletes and their coaches and parents. Little league elbow is an umbrella term, but often refers specifically to medial epicondyle apophysitis and overuse injury affecting the growth plate, or apophysis, on the inside, medial side of the elbow, where the wrist flexor and pronator muscles attach. It is particularly common in young baseball pitchers, typically between the ages of 8 and 16, whose growth plates are still developing and thus represent a biomechanical weak point in the arm. The repetitive high valgus stress during throwing pulls on this growth plate, making it more susceptible to inflammation, stress reaction, or even avulsion, pulling off, compared to the adjacent ligaments in a mature elbow. Patients, usually young throwers, present with localized pain and tenderness right over that bony bump on the inside of the elbow. It's often exacerbated by throwing, swinging a bat or racket, or even just gripping objects firmly. It can also lead to a decreased range of motion in the elbow, particularly extension. Diagnosis is typically made through careful clinical examination, pinpoint tenderness over the medial epicondyle, sometimes pain with resisted wrist flexion or valgus stress. Confirmation is usually via X-ray, which might reveal widening, fragmentation, or even a small separation of the growth plate apophysis on the medial epicondyle compared to the uninjured side.
And the management for that, is it usually conservative?
Yes. The good news is that this injury generally responds very well to conservative management. The cornerstone is complete rest from throwing, often for 4 to 6 weeks or longer, until completely pain-free. Sometimes bracing is used initially. This is followed by a very structured rehabilitation program. This rehab focuses not just on the elbow, but on addressing the underlying contributing factors, strengthening the core, improving hip mobility and lower body mechanics, and crucially, working with coaches on correcting poor throwing mechanics that may have led to excessive elbow stress. We also need to address pitch counts and overall throwing volume. With this approach, over 90% of players are able to return to baseball successfully. However, a significant clinical concern is the relatively high rate of recurrence, estimated at around 13% within 24 months, if those underlying causes like excessive pitch counts, poor mechanics, lack of rest, or year-round play are not properly addressed. Prevention is key here. Surgical intervention is rarely needed for apophysitis, usually only if there has been a significant displaced avulsion fracture of the medial epicondyle that fails to heal with conservative management. This injury really underscores the critical importance of load management, proper technique coaching, and avoiding early sports specialization in youth sports to protect these developing bodies. We need to protect our young athletes.
That's a crucial breakdown of elbow pathologies and the importance of managing young athletes carefully. Beyond these specific areas of the knee, shoulder, and elbow, what about other common injuries we see frequently? Perhaps thinking lower body or general musculoskeletal trauma, things like wrist sprains, broken arms, Achilles ruptures, shin splints, and stress fractures. What should we, as medical professionals, be particularly attuned to in their diagnosis and management pathway?
Yes, let's touch on those, as they are certainly ubiquitous in sports medicine and general practice. Starting with wrist sprains. These involve injuries to the soft tissues ligaments, joint capsule supporting the complex wrist joint. They can range from a mild stretching of ligaments to complete ruptures of crucial intrinsic ligaments, like the scapholina ligament, or the TFCC, triangular fibrocartilage complex. Missing these more severe injuries can lead to chronic instability, pain, and eventual arthritis, so accurate diagnosis is key. Common symptoms are pain immediately after an injury, often a fall onto an outstretched hand, swelling, bruising, and difficulty moving the wrist and hand, particularly with gripping or weight-bearing. Clinically, our first job is to differentiate a simple sprain from an occult fracture, particularly a scaphoid fracture, which can have serious consequences if missed due to its tenuous blood supply, or these more complex ligamentous tears that might require specialist referral or even surgical intervention. Careful examination eliciting tenderness in the anatomical snuff box or pain with specific provocative tests is vital. X-rays are standard, but sometimes MRI or CT is needed. For most simple sprains, a removable splint or brace may be recommended for comfort and protection during activity for perhaps 2 to 6 weeks. Most grade 1 or 2 sprains heal well without major issues within 6 to 12 weeks. However, some residual symptoms like mild pain or stiffness, especially with heavy loading, can linger for up to 6 to 12 months, particularly in higher grade injuries. And again, it's important to remember that patient factors like smoking and diabetes can significantly prolong the healing process due to impaired vascularity and tissue repair mechanisms. We actively encourage simple home exercises almost immediately, within pain limits, things like forearm-supported wrist lifts and bends, ulnar and radial deviation exercises, gentle pronation and supination, and finger-thumb mobility exercises like touching the thumb to each fingertip. These can be started early and repeated regularly to aid recovery and, crucially, prevent stiffness.
Right. Early controlled motion seems key for wrists. What about a straightforward broken arm?
Well, a broken arm is common, often from falls, direct blows, or higher force incidents. Anatomically, the arm comprises the humerus in the upper arm and the radius and ulna in the forearm. The specific bone, the type of fracture, transverse, oblique, spiral, comminuted, its location, shaft, nearer joint, and any displacement or angulation are all paramount for guiding treatment. Is it stable enough for closed reduction and casting, or does it require open reduction and internal fixation, or IF, with plates and screws? A simple, stable broken arm, say a mid-shaft fracture treated in a cast, typically takes about 6 weeks for initial biological bone union to occur. However, the complete recovery, meaning return to full strength and function, can be considerably longer. It depends heavily on the type and specific location of the break. Fractures near the wrist or elbow involving the joint surface often require more extended healing and rehabilitation due to the complex joint mechanics and higher risk of stiffness or post-traumatic arthritis. Initially, patients can expect a high degree of pain and swelling. Interestingly, the regeneration of new nerve fibers within the healing callus during bone repair can sometimes contribute to ongoing discomfort or altered sensation. Managing pain is crucial, but again, as we mentioned, NSAIDs should generally be used cautiously in the early stages of bone healing, as they might slightly impair the process. Paracetamol and sometimes codeine are preferred initially. Complete restoration of full strength, range of motion, and pre-injury function can realistically take up to 2 years in some complex arm fractures, even with dedicated physiotherapy. This is due to factors like muscle atrophy during immobilization, joint stiffness, scar tissue remodeling, and neuromuscular re-education. It's often a longer road than patients expect.
Good to manage those expectations. Achilles rupture, that sounds serious.
An Achilles tendon rupture is indeed a serious, often devastating injury, particularly for athletes. The Achilles is the large tendon at the back of the lower leg, connecting the calf muscles, gastrocnemius and soleus, to the heel bone, calcaneus. It's vital for push-off during walking, running, and jumping. Patients often report hearing or feeling a distinct pop or sensation as though they've been kicked hard in the calf, immediately followed by sharp pain and significant functional loss. They typically can't stand on their toes on that side. It's a hallmark injury for weekend warriors, often occurring in middle-aged individuals playing sports requiring explosive push-off, like squash, tennis, or football. Diagnosis is usually clinical, based on the history and examination findings like a palpable gap in the tendon and a positive Thompson test. Squeezing the calf doesn't produce ankle plantar flexion. Ultrasound or MRI can confirm if needed. Management is somewhat debated between non-operative and operative approaches. Non-operative management involves prolonged immobilization in a cast or boot, gradually bringing the foot up from plantar flexion to neutral. Surgical repair involves suturing the torn ends of the tendon back together. Surgery is often preferred in younger, more active individuals, as it generally offers a lower risk of re-rupture, though slightly higher risk of other complications like infection or nerve irritation, and potentially facilitates an earlier, more predictable return to activity. Regardless of the management choice, this is a severe injury that typically involves a long recovery time. Return to walking normally might take 3-4 months, running 6 to 9 months, and full return to sport often takes 9 to 18 months. The rehabilitation is intensive, focusing on carefully graded loading protocols to promote tendon healing and hypertrophy without causing re-rupture. It's a marathon, not a sprint.
Definitely sounds like it. What about shin splints? That's something many runners complain about.
Yes, shin splints, or more accurately medial tibial stress syndrome, MTSS, refers to exercise-induced pain along the intermedial border of the shin bone tibia. It's caused by repetitive stress leading to inflammation of the periosteum, the outer lining of the bone, where muscles like the tibialis posterior or soleus attach, or possibly a stress reaction within the bone itself. It's a classic overuse injury, very common in runners, military recruits, and athletes involved in sports with repetitive impact. The pain is typically diffuse along the lower 2/3 of the medial tibial border and worsens with activity, often improving with rest initially. If caught early, MTSS typically heals well within 3 to 4 weeks with adequate relative rest, reducing or modifying activity, perhaps cross-training, addressing potential contributing factors like improper footwear, rapid increases in training intensity or volume, too much too soon, and biomechanical issues like overpronation or weak hip and core muscles, leading to poor shock absorption. Physiotherapy plays a key role here in identifying and correcting these factors. However, if it's not recognized and managed early, and the athlete continues to train through the pain, MTSS can progress to more significant tibial stress fractures, which obviously extends the healing time significantly, sometimes requiring months of rest from impact activities. Clinically, the key is differentiating MTSS, more diffuse tenderness over a longer segment of bone, from a focal stress fracture, pinpoint tenderness, or other causes of leg pain like chronic exertional compartment syndrome.
And that leads us to stress fractures themselves.
Exactly. Stress fractures are small cracks, essentially fatigue failures, within bones. They are predominantly overuse injuries that occur when repetitive physical activity places too much cumulative stress on a bone, exceeding its ability to remodel and repair itself. It often starts as a stress reaction or deep bone bruise and progresses to a frank fracture line if the overload continues. They typically affect weight-bearing bones in the lower body. The tibia, shin bone, and fibula are very common sites, as are the metatarsals in the foot, March fracture, the navicular bone in the midfoot, and the calcaneus heel bone. However, they can also occur in the hip, femoral neck, these are high risk, pelvis, lower back, pars interarticularis in gymnast bowlers, and even occasionally in the upper limb, like hands and wrists in certain sports. These injuries account for a significant proportion of all sports injuries, perhaps up to 20% in some estimates, and are a particular concern in endurance athletes, runners, triathletes, or athletes in sports involving repetitive impact, especially if there are underlying factors like poor nutritional status, low bone density, for example, related to the female athlete triad, low energy availability, menstrual dysfunction, low bone density, or biomechanical flaws. The most common symptoms include localized bone pain that typically worsens during or after physical activity and is relieved by rest. There's usually pinpoint tenderness to touch directly over the fracture site and sometimes localized swelling. The pain often starts insidiously and gradually worsens. Diagnosis often requires a high index of suspicion. X-rays may initially be normal, especially in the first few weeks, as the fracture line might not be visible until some healing callus formation occurs. MRI is much more sensitive for early detection, showing bone marrow edema and a stress reaction phase even before a clear fracture line develops. Bone scans can also be used but are less specific. Recovery typically requires a period of complete rest from the aggravating activity, sometimes including non-weight bearing on crutches for lower limb stress fractures, for at least a few weeks. High-impact activities often need to be avoided for several months to allow the bone to heal fully. The bone itself usually takes 6 to 8 weeks to achieve solid union. Crucially, the fracture can easily reoccur or worsen if the individual resumes activity too soon, even if they feel better symptomatically. Return to activity must be very gradual and guided by pain levels. For us as clinicians, the challenge is not just making the diagnosis and advising rest, but digging deeper to identify and correct the underlying training errors, biomechanical issues, or physiological deficits like nutritional deficiencies or hormonal imbalances that predispose the athlete to the stress fracture in the first place. Otherwise, it's likely to happen again.
That's a remarkably thorough dissection of those common injuries and their specific recovery dynamics. It truly highlights the biological realities and the diagnostic challenges we face. Now, here's where it gets really interesting, I think, for us as clinicians making those critical decisions for athletes. Once the initial healing is well underway and a patient has made significant strides in their rehabilitation, the paramount question for any athlete, whether they're professional or amateur, is inevitably, when can I get back in the game? What's your overarching philosophy on return to play, and how do we as a medical community move beyond simply using time elapsed as the sole determinant for such a critical decision?
This is absolutely a critical transition point in the athlete's journey, isn't it? And it's where our clinical acumen, combined with objective data, truly comes into play. It's one of the most important decisions we make. Historically, yes, return-to-play decisions were largely time-based. They often followed a sort of fixed protocol based purely on weeks or months post-injury or post-surgery. You're 6 months post-ACL reconstruction, you're clear to play. That was common. However, modern orthopedic and sports medicine thinking has shifted overwhelmingly towards advocating for a criteria-based approach. This approach prioritizes functional readiness and objective markers of recovery over arbitrary timelines. The underlying philosophy is simple but profound. The ultimate goal isn't merely to get the athlete back onto the field as quickly as possible. It's to ensure the athlete comes back stronger, more resilient, and critically, at a significantly lower risk of re-injury. A re-injury is often far more devastating, both physically and psychologically, than enduring a slightly longer, more thorough initial recovery. Our primary duty, arguably, is to prevent that re-injury cascade.
So function and resilience over just time.
Precisely. We often conceptualize this progression through what we call the rehab performance practice play continuum. This provides a structured, phased framework for safely transitioning athletes from the controlled environment of clinical rehabilitation right back to the unpredictable environment of competitive sport, ensuring each step builds logically and safely upon the last. So in the initial rehab phase, which is our primary clinical focus post-injury or surgery, the emphasis is squarely on protecting the healing surgical tissue or the injured structure. We work meticulously to restore the full normal range of motion, initiate and progress muscle performance with foundational strength and endurance exercises, and effectively control pain and swelling. This is all about establishing a solid biological and biomechanical foundation for future loading. Next, we move into the performance phase, sometimes called rehab plus abate. This stage involves incorporating exercises that begin to more closely mimic the specific biomechanical demands of the athlete's sport, but always with strict respect for the stage of healing tissue. We wouldn't start plyometrics too early after an ACL, for example. Training in this phase should now explicitly address the specific needs for stability, static and dynamic, endurance, strength, and power, across the ranges of motion required for their particular sport. Critically, it also focuses on optimizing the entire kinetic chain, ensuring the body can efficiently generate, transmit, and absorb forces from the ground up through the core to the limbs. This might involve introducing things like plyometrics, agility drills, change of direction work, and more progressive resistance training tailored to the individual.
So moving from general rehab towards sport-specific conditioning.
Exactly. Following that is the practice phase. Here, sport-specific drills are introduced, often initially with modifications to volume, intensity, or complexity. For a footballer, this might mean starting with non-contact drills, then progressing to drills with the ball, increasing speed and complexity, before eventually reintroducing controlled contact. Close monitoring of volume counts, tracking things like the number of throws, jumps, hits, or tackles, becomes absolutely crucial here to prevent overload and identify any early signs of fatigue, pain, or breakdown in technique. And essential communication channels must be established and maintained, a constant dialogue between the medical staff, doctor, physio, the coaches, and the athletes themselves. This is vital for managing expectations, ensuring safety protocols are followed, and collecting real-time feedback on how the athlete is responding physically and mentally to the increased load. This phase really bridges that gap from the controlled clinic environment to the demands of the actual sporting field.
In the final step.
The final stage is play. This involves a gradual, carefully managed reintroduction to full competitive play. And I stress gradual. It's rarely a case of going straight back into a full 90-minute match or a 5-set tennis game. This phase requires meticulous monitoring of symptoms, pain, swelling, instability, ongoing assessment of functional performance. Are they moving well? Are they hesitant? And a planned, progressive increase in playing time and intensity, building up steadily towards 100% of pre-injury demands. For a pitcher, it's a carefully structured return to the mound in games, perhaps starting with limited innings or pitch counts. For a rugby player, it might involve starting with reduced minutes off the bench. It's a carefully managed ascent, ensuring the athlete is not only physically ready, but also mentally prepared and confident to handle the rigors and unpredictability of competition. Mitigating that psychological fear of re-injury, which can often linger even when physically healed, is a key part of this final stage.
That continuum makes a lot of sense. Now, for athletes involved specifically in throwing sports like baseball pitchers or cricketers, the upper extremity is subjected to such immense repetitive stress. What are the specific considerations and perhaps structured progression frameworks essential for these individuals, especially after a major surgical intervention like a UCL reconstruction or a rotator cuff repair?
Yes, you've highlighted a particularly challenging and highly specialized area within sports medicine. The forces placed on the throwing arm, especially at the elite level in professional baseball or cricket, are truly extraordinary, often pushing the very limits of human physiology. For these athletes, return to play is an incredibly meticulous process, often managed over many months, even years sometimes. Let's consider some typical upper extremity injuries and their post-operative return-to-play outcomes to illustrate the timelines and challenges. For ulnar collateral ligament, UCL reconstruction, commonly known as Tommy John surgery, particularly in baseball pitchers, the return-to-play rates are actually quite high, typically reported between 80 and 97% managed to return to some level of play. The average time to return is around 12 months post-surgery. However, and this is a crucial distinction, returning to the same competitive level of play, example pitching in the major leagues, throwing at the same velocity, maintaining performance statistics, see slightly lower success rates, perhaps between 67 and 87%, and tends to take longer, averaging around 15 months. The clinical considerations throughout this lengthy process are extensive. We meticulously monitor elbow valgus loads, that's the immense stress placed on the inside of the elbow during the late cocking and acceleration phases of throwing. We use biomechanical analysis where possible to assess throwing mechanics. Ensuring the athlete regains and maintains full symmetrical elbow range of motion is also absolutely paramount, as even a small loss of extension or flexion can significantly impact throwing mechanics and efficiency downstream.
So returning is one thing, returning to the previous level is another.
Absolutely. For SLAP, superior labral anterior posterior, repair of a tear in the labrum, the cartilage rim around the shoulder socket, often where the biceps tendon attaches, the overall return to sport rate is reported around 69%. But this figure varies significantly by sport and position. Pitchers, again, seem to fare less well, with a reported return rate of perhaps only 57%, while other types of athletes might achieve closer to 87%. This really underscores the unique and extreme demands of pitching on the shoulder joint. The average time to return is typically around 6 months. Close attention must be paid to any persistent biceps symptoms, as the biceps tendon is often involved or irritated in SLAP lesions and can be a source of ongoing pain if not managed appropriately during rehab.
And rotator cuff repairs.
In cases of rotator cuff repair, or perhaps shoulder stabilization surgery, like a Bankart repair for dislocations, approximately 67% of athletes are reported to return to sport, with an average recovery period, again around 6 months to initiate return, but often longer for full performance. Critical factors for success here include achieving full, pain-free range of motion without restriction, and very carefully progressing the loading on the repaired tendons or stabilized structures. We need to ensure they can withstand the high dynamic forces of athletic activity, particularly overhead or contact sports, without re-tearing or re-dislocating. This involves a very delicate balance between pushing the rehabilitation forward to regain strength and function and respecting the biological healing time of the tendon to bone or ligament repair. Go too fast and the repair can fail.
It sounds like a real balancing act. Is there a standard framework for getting throwers back?
Yes. For all throwing athletes post-injury or surgery, a structured return-to-throwing program is absolutely paramount. It's designed to prevent re-injury and setbacks by imposing a very methodical, gradual buildup of throwing stress. Rushing this is a recipe for disaster. For us as clinicians, it's about micromanaging the volume, intensity, frequency, and mechanics at each step. A typical program might look like this, in phases. Step 1. Build throwing volume. This starts with very low-intensity throws, often called interval throwing, typically at short distances, say 30-60 feet, with a perceived effort of only 4 to 5 out of 10. The aim here is simply to reestablish the neuromuscular pattern of the throwing motion without placing high stress on the healing tissues. We usually advise starting with maybe 3 throwing days per week, gradually increasing the number of throws per session and per week, without increasing the intensity or frequency initially, just building that base volume tolerance. Step 2. Add throwing intensity with long toss. Once a volume base is established, athletes gradually increase their throwing distance, perhaps by about 15 feet every 1 to 2 weeks, typically using a high arc trajectory. For younger players, the goal is often to build up to at least 120 feet of pain-free long toss before they even think about progressing to throwing off a mound. This distance helps develop arm strength, endurance, and promotes proper throwing mechanics, ensuring the arm is getting out front and decelerating properly under increasing load. This phase focuses on tolerating higher intensity and refining mechanics under that load. Step 3. Add increased throwing frequency. Once intensity is tolerated, the program might progress from 3 throwing days per week up to 5 or even 6 days per week for most high-level athletes. However, this needs careful structuring. For example, it might involve 2 harder throwing days, perhaps long toss or starting light bullpen sessions, 1 medium effort day, and 3 light throwing or active recovery days. This allows for adequate recovery and prevents cumulative overtraining. We meticulously track pitch counts, recovery status, asking about soreness, fatigue, and objective measures like velocity if possible. Finally, step 4. Position-specific throwing. Once the general throwing progression is successfully completed without issues, athletes then reintegrate into their specific positional demands. For pitchers, this means initiating a structured bullpen progression, throwing off the mound, gradually increasing the distance, intensity, percentage effort, number of pitches, and incorporating different types of pitches, fastballs first, then off speed. This is followed by throwing against live hitters, live batting practice, and eventually progressing into simulated game action and then actual competitive games, starting with limited pitch counts or innings. For catchers, they need to practice and slowly progress their pop throws to second base, which are significantly more stressful in the elbow and shoulder than typical long toss due to the rapid, explosive nature of the movement and the need for quick release and accuracy. Each step in this entire progression must be carefully monitored by the medical team and coaches, ensuring the athlete is progressing safely and, critically, without any recurrence of symptoms. Any significant setback requires stepping back in the progression and reassessing. There are no shortcuts.
That detailed throwing progression framework really highlights the strategic, patient approach required. It also leads us naturally to something equally critical, perhaps even more so in the long run: prevention. We always say prevention is better than cure in medicine, and that seems particularly true in sports. What are the fundamental strategies we, as medical professionals, should be implementing ourselves and advocating for with athletes, coaches, and parents to minimize the risk of both initial injuries and, crucially, their recurrence, which can be so devastating for an athlete's career and well-being?
This is truly where we can make the greatest long-term impact, shifting from a purely reactive model to a proactive one. Firstly, we must continually encourage athletes at all levels to know their body's limits and listen to the signals it sends. It's absolutely crucial not to overdo it, especially when starting a new activity, returning from an injury layoff, or during periods of rapid increase in training load or competition frequency. We need to educate them on the warning signs of overtraining, persistent fatigue, decreased performance, disturbed sleep, mood changes, and the importance of planned rest, recovery, and periodization within their training schedules. Progressive overload is the key principle for adaptation. But rushing that progression, doing too much too soon, invites injury. Secondly, we must constantly emphasize the importance of correct technique and posture. Whether it's holding a tennis racket correctly, maintaining proper form during weightlifting, executing a throwing motion efficiently, or landing mechanics after a jump, poor biomechanics place unnecessary, abnormal stresses on joints, ligaments, and tendons, making them vulnerable. This is where collaboration with knowledgeable coaches and athletic trainers is absolutely vital. We, as medical professionals, can identify biomechanical deficits or injury risks, and they have the expertise to help correct them through specific drills and coaching cues. It's a team approach.
So technique is fundamental.
Fundamental. This links directly to the third point. Stress the importance of investing in and using appropriate equipment. This ranges from well-fitting running shoes that offer the right type and amount of support and cushioning for their foot type and running style and replacing them regularly, to essential protective gear relevant to their sport. Think mouth guards in contact sports, shin pads in football, appropriate helmets, or even specific bracing for previously injured or vulnerable joints, if indicated. These aren't just accessories. They're fundamental protective measures that can significantly reduce injury risk. Furthermore, we must always prioritize and educate athletes on prioritizing a thorough warm-up before any exercise session. Around 10 minutes of dynamic activity to prepare the muscles, joints, and nervous system by increasing blood flow, muscle temperature, and elasticity. And equally important, incorporating dedicated stretching or mobility work after sport or training sessions to help loosen muscles, maintain flexibility, and prevent post-exercise tightness or imbalances developing over time. These seemingly simple steps are surprisingly vital in reducing muscle strains and improving overall movement quality.
What about managing the actual amount of training?
Yes, load management is absolutely key, particularly in sports involving high volumes of repetitive activity, like running or throwing, as we just discussed extensively for throwers. We, and the coaches we work with, must meticulously monitor the overall training load that includes not just the intensity but also the volume, duration, frequency, repetitions, and type of activity. For throwers, this means tracking pitch counts per game, per week, and for season, adhering to age-appropriate guidelines. We need to be vigilant for those early signs of fatigue, like a pitcher losing velocity late in the game or a runner's form breaking down, and be prepared to adjust training loads accordingly, building in adequate rest days and recovery periods. This proactive approach helps prevent the cumulative stress that leads directly to overuse injuries like Little League elbow, stress fractures, or chronic tendinopathies. We often advise coaches and athletes to utilize simple tools like tracking daily training logs, using subjective wellness questionnaires, or monitoring rate of perceived exertion, RPE, to help gauge athlete fatigue and readiness to train.
And what about factors beyond the training itself?
Crucial. We need to encourage athletes to embrace a high-performance lifestyle that supports recovery and resilience. This extends far beyond the hours spent training or competing. It encompasses foundational elements like ensuring adequate sleep, ideally 8 hours of quality sleep per night, for optimal physical and cognitive recovery, muscle repair, and hormone regulation. Consuming a high-quality, balanced diet is also vital, rich in lean protein for tissue repair, complex carbohydrates for sustained energy, healthy fats, and a wide variety of colorful fruits and vegetables to provide essential micronutrients, vitamins, and antioxidants to combat exercise-induced inflammation. Maintaining optimal hydration levels by drinking sufficient water throughout the day, A rough guide is 0.5 to 1 ounce per pound, or about 30-60 milliliters per kilograms of body weight daily, adjusted for activity and climate, is also critical for almost every bodily function, including cellular processes, temperature regulation, and joint lubrication. Our role here often involves providing basic nutritional and lifestyle counseling, or referring to sports dietitians or psychologists when needed. These factors are often overlooked but have a huge impact.
So sleep, nutrition, hydration, the basics matter.
They matter immensely.
Yeah.
Furthermore, we must absolutely instill the rule: never play through sharp or worsening pain. Pain is the body's primary protective signal that something is amiss and requires attention. Ignoring it, or trying to mask it just to compete, is often a direct path to escalating a minor, manageable issue into a major, potentially career-altering chronic injury. We need to educate athletes, coaches, and parents on the difference between acceptable muscle soreness from exertion, DOMS, and true injury pain, and create an environment where athletes feel empowered to report symptoms honestly without fear of negative consequences, like being benched indefinitely. Early reporting leads to early intervention.
And proactive checkups.
Yes, finally, regular clinical checkups can be very valuable, especially for athletes engaging in high-intensity, high-volume, or high-risk sports. Advise periodic check-ins with a physiotherapist or a sports doctor, perhaps preseason or midseason, to proactively screen for and monitor subtle changes in range of motion, muscle strength imbalances, flexibility deficits, or movement patterns that can predispose them to future injury. Catching these things early allows for corrective interventions before they cause a problem. We also need to educate athletes to recognize early warning signs themselves. Things like noticing increased arm or leg fatigue that doesn't recover as usual between sessions, struggling to warm up, feeling heavy-legged, or seeing a noticeable unexplained decrease in their performance metrics like throwing velocity, sprint speed, or jump height. Intervening early when these subtle signs appear, perhaps by adjusting training load or seeking assessment, can often prevent a minor niggle or fatigue state from escalating into a significant time loss injury. It is all about fostering a holistic, preventative mindset, embedding proactive health management and self-awareness into the athlete's regular routine.
That's a truly comprehensive prevention strategy covering so many angles. Now, linking back to the return to play decision, this is where it gets really interesting and perhaps technically most challenging for us as medical professionals. We're tasked with making objective, data-driven decisions about readiness. How do we actually objectively measure an athlete's readiness to return to play? Particularly thinking about upper extremity injuries where, as you said, the biomechanical demands can vary so widely across different sports. What are the gold standard assessment tools? And perhaps more importantly, how do we interpret them in context?
This is indeed the cutting edge, or at least the best practice standard, in modern sports orthopedics and rehabilitation. It's an area where we've seen significant evolution, moving away from purely subjective assessment, how do you feel, or time days clearance, toward incorporating robust objective data. The imperative for these objective measures stems directly from the fact that unlike lower extremity biomechanics, where activities like running, jumping, landing tend to be somewhat more consistent across many sports, upper extremity demands are incredibly variable and highly sport-specific. Think of the precision, coordination, and high-velocity demands on a pitcher's shoulder and elbow, compared to the repetitive, lower-force but high-endurance demands on a swimmer's shoulder, or the high-impact, closed-chain demands on a rugby player's shoulder during a tackle. This huge variability necessitates highly tailored and objective assessment tools. We can't just use the same tests for everyone and expect them to be meaningful. Historically, as you alluded to, there were actually limitations in the published evidence supporting specific upper extremity return-to-play test batteries. This lack of clear guidance led to concerted efforts within the sports medicine community, including initiatives like a modified Delphi survey among international experts, to try and establish a consensus on best practices for assessing upper limb readiness.
So what did that expert consensus find? What should we be using?
Through such consensus-building processes, a clear agreement was reached among experts regarding the crucial role of employing a functional testing algorithm, or battery of tests. This algorithm shouldn't be ad hoc. It should be systematically developed and applied, integrating several critical factors together. These factors typically include a deep understanding of the specific biomechanical demands of the athlete's sport and position. We must know what they need to do. Considering the estimated tissue healing timeframes, is the biology ready? Comprehensive assessment of pain, using patient-reported outcome measures, and assessing pain during and after activity. Objective strength assessment, using precise measurement tools. And finally, evaluating performance on validated physical performance tests that mimic functional demands. It's really a multi-layered funnel system, progressively assessing different aspects of readiness.
Okay, let's break that down. Starting with strength testing, how do we get objective data there?
Right, regarding strength testing methodologies, we really need to move far beyond rudimentary manual muscle testing, like the Oxford Scale 0-5. While useful for detecting gross weakness, it's notoriously subjective and lacks sensitivity for detecting the more subtle deficits often present in athletes nearing return to play. More objective and reliable data can and should be obtained using devices like handheld dynamometers, HHDs. These provide quantifiable force measurements in kilograms or pounds. Ideally, for maximum reliability, the HHD should be stabilized against a fixed point, like a wall or therapist's body, rather than just held freehand, to minimize tester variability. Even better, though less commonly available, are inline dynamometers or isokinetic testing machines, which provide even more precise data, particularly on dynamic strength through range. Key metrics we track include the external rotation to internal rotation, ER-IR strength ratio in the shoulder. We typically aim for the external rotators to be around 66–75%, as strong as the internal rotators in a healthy throwing shoulder. We also compare absolute strength values, for example peak force and kg, to available normative data for specific sports populations, age groups, and positions, if available. And the Limb Symmetry Index, LSI, is also a critical metric. This compares the strength of the injured limb to the uninjured, contralateral limb, expressed as a percentage. Injured limb strength, uninjured limb strength 100. In healthy, uninjured overhead athletes, the dominant arm is typically expected to demonstrate around 10–15% greater strength than the non-dominant arm in key muscle groups, like internal rotators or elbow flexors. So achieving at least 90% and ideally closer to 100%, or even exceeding it for some measures compared to the uninjured side, is often a key criterion before return to play, indicating restoration of symmetrical strength. This allows us to quantify any residual deficits objectively.
That's very clear on the objective strength measurements using dynamometry. But beyond measuring isolated muscle strength, what specific physical performance tests give us the clearest, most objective picture of an athlete's readiness to return to the dynamic, multiplanar, often high-speed demands placed on the upper body in their specific sport? What functional tests are recommended?
Yes, that's the crucial next step, assessing function. Based on that expert consensus work like the Delphi study, there are several highly regarded physical performance tests that offer crucial functional insight into the upper limb's capacity. The top 3 tests that achieve the highest level of agreement among experts really highlight their importance in our assessment battery before clearing an athlete. First, the Closed Kinetic Chain Upper Extremity Stability Test, often abbreviated as CKCUST. This test is highly regarded because it evaluates both muscular endurance and dynamic stability of the entire upper extremity and shoulder girdle in a closed-chain weight-bearing position, which reflects functional demands in many sports, for example, gymnastics, contact sports, even stabilizing during running. The athlete assumes a push-up position with their hands placed 36 inches apart on the floor. They then alternately lift one hand to touch the back of the opposite hand across the midline as many times as possible in 15 seconds. We count the number of touches. Good performance on the CKCUS correlates well with high performance in objective strength assessments. It boasts excellent retest reliability, meaning the results are consistent. And importantly, there are established normative values available for different populations, making it practical, informative, and quick to administer in a clinical setting. It gives us a good measure of dynamic upper limb stability and endurance.
Okay, CKCUE asked for stability. What else?
Second, and perhaps surprisingly to some clinicians who focus only on the injured limb, are tests of the lower extremity and core. These are considered surprisingly vital by experts due to that principle we mentioned earlier, regional interdependence. Optimal upper extremity function, especially in powerful movements like throwing or hitting, fundamentally relies on the efficient generation, transmission, and absorption of forces throughout the entire kinetic chain, which originates from the ground through the legs and core up to the arm. A weak core, poor hip control, or limited ankle mobility, for example, can force the shoulder or elbow to compensate and generate excessive force, significantly increasing injury risk or hindering performance upon return. Therefore, assessing the foundation is crucial. Specific examples of tests commonly used include the lower extremity Y-balance test, assessing dynamic balance and reach, single leg balance assessments, static balance, objective hip abductor strength measurements using HHD, timed side planks to failure for core endurance, particularly lateral chain, and single leg bridges for gluteal strength and control. Assessing these areas provides critical insight into the athlete's overall kinetic chain efficiency and potential weak links that could affect their upper limb function or injury risk.
That's a really important point about the kinetic chain. What's the third key test?
The third top-agreed test is the seated medicine ball throw, often called the seated shot put test. This test directly assesses explosive upper extremity power, which is obviously critical for throwing, striking, and overhead sports. The athlete sits on the floor with their back firmly supported against a wall to isolate the upper body and core. They then hold a medicine ball, typically 6 pounds or around 3 kilograms, with both hands against their chest and propel it forward horizontally as far as possible using only their arms and trunk. We measure the distance the ball travels. This test demonstrates excellent reliability. Normative values are available and typically suggest the dominant arm performs around 106% better, throws 6% further, than the non-dominant arm in healthy, asymptomatic athletes. This gives us a clear benchmark for assessing power symmetry upon return from injury.
So CKCUAs for stability, core lower limb tests for the kinetic chain, and seated med ball throw for power. Are there other useful tests?
Yes, beyond these top 3 consensus tests, other relevant performance tests can provide complementary information depending on the athlete and their sport. For example, the prone T-ball drop test is another test that evaluates endurance and dynamic stability, particularly of the scapular muscles. The athlete lies prone, face down, on a table with their arm abducted to 90 degrees, holding a lightweight, for example, a 2-pound ball. They repeatedly drop and catch the ball as many times as possible in 30 seconds. A proposed limb symmetry index of 110%, dominant arm performing 10% better, has been suggested for this, although normative data is still developing. The simple push-up test remains a reliable measure of muscular endurance in the upper extremity. It's typically performed for as many repetitions as possible within a set time, maybe still 15 seconds or 1-2 minutes, or until failure. It has very high reported retest reliability, around 0.96. The upper quarter Y balance test is analogous to the lower extremity version, but performed with the hands reaching in 3 directions while maintaining stability on the stance arm. It explores closed kinetic chain performance and dynamic balance in the upper quarter, and shows moderate correlation with core stability, CKCUS performance, and push-ups, offering another perspective on integrated upper limb function. Lastly, the athletic shoulder test, ASH, is a newer test developed around 2018, specifically designed for assessing readiness in athletes involved in tackling positions, like rugby. It employs a long lever isometric strength assessment in different directions, using a handheld dynamometer, and has shown excellent reliability. So, depending on the athlete's sport and the nature of their injury, we might select a battery of these tests to provide a comprehensive functional assessment of the upper limb's readiness to withstand the specific forces and demands of their sport.
This is remarkably comprehensive, and it truly paints a picture of the objective data potentially available to us beyond just time or subjective feeling. So, the final critical step. How do we integrate all these disparate pieces of data, the estimated biological tissue healing timelines, the observed range of motion, the objective strength metrics from dynamometry, and the results from this battery of physical performance tests to make that critical, often high-stakes, final decision on when a patient is truly ready and safe for return to play? What does that integrated decision-making framework look like in actual clinical practice?
It is unequivocally a multifaceted and nuanced process, as you say. It really moves beyond a single test result or a single professional's opinion, giving a simple yes or no answer. Ideally, it involves a collaborative decision-making process, often involving a multidisciplinary team, the surgeon, if involved, the physiotherapist who has worked most closely with the athlete, perhaps a strength and conditioning coach, sometimes a sports psychologist, and of course the athlete themselves. We use an integrated decision-making framework that systematically assesses multiple domains before clearing an athlete. Firstly, we absolutely confirm the athlete is operating within the expected biological tissue healing timelines for their specific injury or surgery. Biology needs adequate time, and we must respect that fundamental principle. For instance, a bone graft needs time to incorporate. A ligament graft needs time to mature and revascularize. Pushing too soon, even if they feel good and test well, can lead to biological failure of the repair or reconstruction. So time is still a factor, just not the only factor. Next, we meticulously verify they possess full and expected range of motion in the affected joint, comparing it to the contralateral limb and pre-injury levels if known. There should be no significant limitations that could compromise function, alter biomechanics, or indicate residual problems like stiffness or scar tissue impingement. Crucially, we continually assess pain and patient-reported outcomes, PROs. Are there any persistent concerns flagged up on validated patient-reported outcome scales, like the DASH, Quick Dash, or Oxford scores for the upper extremity? And perhaps most importantly, do they experience any significant pain during or critically in the 24 hours after performing demanding rehabilitation exercises, sport-specific drills, or practice sessions? Post-activity pain, swelling, or irritability is often a primary indicator that the current load is exceeding the tissue's capacity and it isn't quite ready for that level of stress. We need to carefully differentiate between acceptable muscle soreness from new training and true nociceptive pain originating from the injured structure.
So listening to the patient's feedback is still vital.
Absolutely vital. We then rigorously evaluate strength. Do they demonstrate any lingering clinically significant strength deficits when compared objectively, using HHG or isokinetics, to the contralateral limb or established normative values, particularly in the muscle groups critical for their specific sport demands? Are they meeting those limb symmetry index goals, for example, 90%? And just as importantly, are they showing consistent progression in their strength gains throughout the later stages of rehabilitation? This indicates whether they have developed the necessary muscular capacity to withstand and control sport-specific loads. We look for that symmetry, appropriate functional ratios like the ER-IR ratio, and overall robustness. Finally, the physical performance tests we discussed provide that crucial functional validation. Do they exhibit adequate symmetry on functional tests like the CKCU-SID, single-leg hop tests for lower limb, or the seated medicine ball throw? Typically, we look for the injured limb to perform at least 90% and ideally closer to 100% or even 110% for power tests in dominant limbs of the non-dominant limb. Do their results compare favorably to available normative data for their sport, age, and level? And all of this must be achieved without any reported pain or compensatory movements during the tests themselves. It's really about combining evidence of structural integrity, from imaging and time, with restoration of impairment, range of motion strength, and demonstrated functional capacity, all while ensuring the patient feels confident and pain-free during demanding activities. Only when all these boxes are ticked can we start to consider clearance.
And even then, the return needs careful management.
Exactly. Once all these criteria are meticulously met and the green light is given by the entire team, the reintroduction to competitive play, as we outlined in the continuum, must still be meticulously managed. It's not job done. This involves that gradual increase in intensity and volume, carefully monitoring play counts, pitch counts, match minutes, hit counts, or rep counts, depending on the sport, to ensure they don't jump back in too aggressively after a long layoff. And of course, maintaining continuous open communication with the patient is paramount. We need to actively follow up, asking how they're coping, addressing any new symptoms or concerns as they arise. This ongoing monitoring is crucial for long-term success and, critically, for catching any potential issues early to prevent that disheartening cycle of re-injury. Our role as clinicians extends beyond the point of clearance. It's about guiding them safely back to sustained participation.
This deep dive has undeniably illuminated the huge complexities and the critical stages involved in sports injury recovery. We've gone from the immediate aftermath and initial management right through to the really nuanced, objective process of getting our athletes safely back to peak performance. We've explored everything from the fundamental RICE method and its evolving understanding through to advanced surgical interventions, and now these precise subjective metrics that should be driving our crucial return-to-play decisions.
Yes, and what's truly fascinating, I think, is the consistent thread weaving through all these discussions. It comes back to patience from both the athlete and the clinician. An unwavering commitment to dedicated, structured rehabilitation. There are no shortcuts. And a truly tailored, individualized, often multidisciplinary approach. These elements seem absolutely non-negotiable for achieving optimal biological healing and, critically, for preventing that cycle of re-injury, which is often worse than the first. The human body's capacity to heal is quite immense and resilient, isn't it? But it demands both profound respect for its biological processes and timelines and meticulous expert guidance from us, the medical and therapy professionals.
Indeed. And for us as medical professionals, having a comprehensive understanding of these recovery timelines, the rehabilitation principles, the preventative strategies, and the myriad of factors at play really empowers us to provide the most effective, evidence-based guidance and support for our patients, helping them navigate their challenging but ultimately, hopefully, rewarding recovery journeys. If you found this deep dive valuable today, please do consider rating and sharing it to help more of our colleagues benefit from these insights. Finally, perhaps a provocative thought for you to mull over as you reflect on today's discussion. If these comprehensive prevention programs, early intervention strategies, and meticulous load management approaches are demonstrably so effective at mitigating injury, risk, and recurrence, how might we, as a collective medical and sporting community, fundamentally redefine the typical structure of an athlete's season or career? How could we pivot from what is often a largely reactive treatment paradigm towards a genuinely proactive injury avoidance model? Could we ensure better long-term athletic health and sustained peak performance for everyone, right from the aspiring junior player up to the seasoned professional, truly safeguarding their careers and their future well-being? Something to think about. That's all for this Deep Dive Ortho. Thank you for joining us.
Thank you. It's been a pleasure.